Hello, all. Welcome back to another podcast. This is Rohit again. We have with us Dr. Mark Manary. He is a professor of pediatrics at Washington University and specializes in childhood malnutrition, an expert in malnutrition. So, super excited to have him today. Lot to learn in this one. So, Doctor, would you like to introduce yourself?
Yes, I'm a an American, obviously by my accent. I've spent my life working in sub-Saharan Africa, though, and largely focused on malnutrition. I'm an old person, so I'm working on 40 years in sub-Saharan Africa.
Awesome. Sounds like you have a lot of experience, and that's exactly why you're here. Um, I wanted to ask, just with your experience in Africa and also just childhood malnutrition, what really first drew you to this field of childhood malnutrition, and how did your early experiences shape the direction of your work? Because you've been there, like you said, 40 years.
Yeah. Well, I'm a bit unusual, I think, in the sense that I'm drawn to things that need to be solved rather than things that somehow interest me or things that I think I have skill set for. So when we first went to Africa, that was really clear to me that kids were sick because they didn't get enough to eat. So that has been the driving focus, how to work there in more successfully with kids. When I started really focusing on malnutrition in '94, they would put these kids in a certain ward, a certain section of the hospital, and the re treatment outcomes were very poor. I mean, they were bad. So I knew that the area needed a lot of attention.
I see. Yeah, and I think def just hearing about it versus actually going there, definitely can make a huge difference. So any moments that you can share, maybe just one moment from your field work in Africa that really fundamentally changed how you think about nutrition and community health, like one specific thing.
I think that when we we're well known for the thing we're best known for is home-based therapy. Okay. So taking children who are very sick, severely malnourished, and they're being treated at home by their mothers. Of course, they're coming to clinic at a periodic basis. And but prior to that, we had spent years, even decade, working in hospitals, taking care of these children as inpatients. And what we found was that the, the children could deteriorate very quickly and unexpectedly. And when we started home-based therapy in 2001, they didn't. And so I would say the amazing thing to me was after a couple of weeks in that clinic, I think everyone's coming back and they're alive. What's the deal here? And that really underlined to me that home-based therapy is the way to go.
Wow, that's definitely very insightful. In terms of home-based therapy is one thing that you mentioned, but also ready to use therapeutic food. That's something that I know you have a background in, you really helped bring about. Now, that's definitely transformed global malnutrition treatment. So, what were some key scientific breakthroughs that made ready to use therapeutic food, RUTF, sorry, possible?
So as I said, I was working in a village in '99 with these kind of kids, trying to work on prevention programs and things that could be done in the community. And I could see that every spare minute of this mother's time, or every minute of this mother's time, was consumed by physical work. If she were told that she needed to feed somebody 6 times a day, that would just be an impossible ask. So I said to myself, what we need is a food that wasn't spoiled in the tropics, bacteria can't grow in it, is full of fat and protein, something that's just ready to go. And that's to an American, that's peanut butter. And that's how we got started with peanut butter. So being right in the field and saying what would really be most appropriate for home-based therapy here. And so RUTF allowed us to do home-based therapy. It was the vehicle that made that possible.
Wow, that's I learned how to learn a lot just right there. That's amazing. That's very insightful and honorable. How do you think that the global adoption of it has changed outcomes for children? You gave kind of one example, but how do you think that's really changed the outcomes for children and also any challenges that still remain in scaling its use and just related to RUTF?
I mean, we were looking at following the inpatient strategy was resulting, first of all, in very low coverage because people didn't come for help until they were quite ill. And two, 25% recovery rates. We just send these people home with peanut butter, with peanut butter, milk powder, vitamins and minerals mixed together. And we then now suddenly get that to be 75 or 95% recovery for the full RUTF. So the first leap in 2001 was quantum, right? I mean, you didn't need to be a statistician to figure out we need to continue this because it's really working.
Mm.
So that, I think that recovery rate. Another way to look at it is um, about 20 some million kids died of severe acute malnutrition in 2000, and about 3.5 million kids worldwide died in last year.
Yeah, huge.
So it's, decreasing death rates and working with recovery rates to be six, sevenfold.
Mm. Wow. That's, I mean, awesome, amazing to hear such a huge impact. In terms of kind of touching on the malnutrition again, I know it's not something that just affects growth because we see it like malnutrition, you think of like a little child, malnourished child that doesn't really have much to eat,
Mhm.
but it also affects long-term organ health. So, in your work and as a doctor, how have you seen malnutrition or severe malnutrition in particular to really impact the liver, immunity, and overall just development?
I mean, that's a really good point that you make there. You see the kid, they look like skin and bones. They have a really little arm up here, but inside their heart is paper thin. And inside their liver looks like a depleted sack. So, the body is consuming itself when it doesn't have the basics that it needs to sustain itself.
Mm. So it's a lot more than what you see on the outside, it sounds
Oh,
like.
yes. I mean, yeah. And most of the children, if they're going to have a bad outcome, it's going to become with a severe infection because
Mm.
their immune system's shot.
Mm. Okay. And I know that with a lot of this work that you were doing, as we were talking about in Africa, um, what do you think can be applied to regions like India and West Bengal, where undernutrition, micronutrient deficiencies and all that remain significant, but slightly different culture, genetics, community, slight differences there.
Yeah, I mean, I was in West Bengal for that very purpose a couple of years ago. And I can say that, if you can intervene before they get to this point that I'm alluding to, when they're at the edge, at death's door or whatever,
Mm.
I mean, that's saving. That's a saving for that kid. And so, if you can have a supplement that is full of micronutrients and has very high quality protein, then that can turn that corner. That can do that. And the reason to have the food have so much fat in it is because there's twice as much energy or calories in fat than there is in protein or carbohydrate. So you want a fat-rich food, you want a protein-rich food, and you want to make sure that you've supplemented it and over-supplemented it with micronutrients.
So, okay. And in your view, just based on what you've seen and the work that you've done, what role do you think nonprofits, community-based organizations, they should be playing in preventing malnutrition before it becomes severe, as you were saying? Because, the more strength in numbers, basically.
hmm I think so. I think I mean the local recipes that are appropriate are can be made out of most diets anywhere in the world. They're not the same, obviously. And I think in West Bengal we were using some mustard seed oil and so forth. And in Africa we use a lot of peanut. Milk powder is ubiquitous. You've got to always have some of the it's the most magic ingredient whatsoever. You know,
Mm.
Mammals were evolved to grow on milk.
Mhm.
So there you go.
Yeah. But it sounds like it was kind of catered to the food that was available and generally in the area, local, known.
Exactly, exactly. I mean, you want you don't want something that that comes from not so nothing wrong with being far away, but comes from some exogenous place that
Mhm.
maybe you can have it infrequently at special times. I
Mhm.
mean, you want to get incorporated in the diet. In most cultures, are eating a bowl of a cereal porridge of some sort, rice, maize, things like that. So what you want to do is you want to add something to that to make it like a powerful packet of RUTF.
Yeah, so kind of cater it to the demographic and also
Hmm.
what's available, what's familiar as well.
Yep.
Okay. And how do you think what do you think the role of governments and public health systems, like how can they better integrate these therapeutic foods, community-based care into their nutrition strategies to again be on the prevention side?
I think that they they can be there to rescue people that um, have fallen into severe malnutrition. I think it's better to work through educational products with locally available foods and like if you have an advocate in this is I'm thinking an African context, but we have mo open air markets. Lots of people come on market day. They're walking from stall to stall. They're looking at different kinds of food. You have a community health advocate there saying to mothers, "Hey, you've got a little baby with you. You've got a 12-month old or a 15-month old. Some eating some of these little fish, grind them up. Don't just give the kid the whole fish. That's going to give the child a lot of calcium, a lot of really good protein, some fats that are essential for neurocognition. Somehow getting to the place where mothers are making decisions about what to feed kids. And when we think of India, I'm not sure about West Bengal, but over in the east, I mean, excuse me, of the west side of India, grandmothers are the key there. You've got to get to the grandmothers, and they'll make sure the kids get what they need.
Yeah. Yeah, I guess, yeah, basically cater to the culture as well and cater to what the norm is. And then again, we talked about ready to use therapeutic food a lot, RUTF. But with the rate of technological change lately and a lot of the stuff that we've been seeing in the past decade, what innovations in therapeutic foods or public health nutrition, malnutrition prevention, or cures excite you most for the next decade? What do you see?
Well, from the time we first started using it in 2001, I mean, we've completely changed through the doing clinical trials. So first of all, one of the tenets of my work, and I think should be of everyone's, is evidence-based, right? Just because it seemed like a good idea doesn't really mean it is a good idea. Put it to the test, compare it to the standard of care, see what happens. And we did that with our fats, and we showed that we could add 6 to 15 IQ points to every child we treated if we used certain kind of omega-3 fatty acids, which are more prevalent in fish. Um, that's 10% of our brains are made of one certain kind of fat called DHA. And if you're not giving that in the diet of the kid's been depleted of everything. They haven't had enough of everything. I mean, and they you can't make the body's metabolic capacity is able to alter certain similar metabolites. They're able to take something and change it a little bit, but they can't make from sugar, they can't make fats, or they can't make protein from fat, or they can't make fat from protein. That's why those are called different uh, macronutrients. So yeah, with paying attention to the fats, we've really helped with cognition. I think that another thing we've done is infection control. The child seems to have routine administration of antibiotics. And the child seems to have some kind of infection, be quick because this is to treat the child with an antibiotic because this is a child who's going to be quick to die on you if you don't get that. So, and go work with the best. I mean, who cares more about this child than their mother? No one. That's it. That's who you need to work with, the mothers. Um, and community advocates can be also helpful to the mothers and getting proper feeding. So I think those are areas we've moved into. You know, it used to be in some ways a very specialized food that came from Europe, and now it's made all over the world. That's why it's so much more available. I mean, when we think about treating severe acute malnutrition, I mean, in the early 2000s with home-based therapy, the number of people treated were in the tens of thousands or something like that. But I mean, in 2024, we're talking about 40 million. And it's used for a time limited. It's not, we're not changing their diet forever. We're not saying this food needs to be in your diet forever. Da, 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 da. The 6 weeks, 6 weeks of this food will turn the corner. You can think of it as like filling up all the empty receptacles with nutrients for 6 weeks, and that'll be enough to carry the child.
Yeah, not a long-term thing, but just something to prevent it before it gets worse or before it's kind of
Yeah, as it starts, as it onsets, that's when you treat it.
Mhm. Yeah. Well, that was a lot that we covered in a very short amount of time. I think one last question that I really have is for young physicians, scientists, nonprofit leaders, and really anyone listening today, but I guess especially those people kind of involved in the area. What advice would you offer about working at the intersection of science, but and like, being a doctor, you are a doctor yourself, but also humanitarian service?
I think that you look for ways to realize that as a physician, as a professional, as a scientist, I mean, you're intervening with somebody at one point in time, but look in ways to augment that and sustain that. So we talked a lot about children, and children are convenient in the sense that they have a caretaker. So you work with that caretaker, but uh, older adults too also can have malnutrition. I mean, this isn't just a child's problem. And there you want to get a brief sense of who's in this adults caring community and who can I also build a bridge with. So realize that most of the healing, most of the therapeutic care is going to happen over the course of weeks and many days, and to try to figure out how that's going to happen. Not as an intellectual puzzle, but as it's usually a relationship, right? You get the trust of the mother, the trust of the adult. They've seen that they get some help already. More of it, they'll get even more help.
Yeah, so kind of going, it sounds like it's based on the home-based care that you said, and really not just looking at the individual, but really looking at the family, who, the people that care most about the person are the ones that are
Hmm.
more likely to take part in helping and take part in preventing and or curing whatever the issue is.
Yeah.
Cool. That was all I had. Definitely covered a lot. And I want to thank you again so much for your time today. You got decades of experience that you provided, and I know we could go on forever if we kept talking, but there's a lot to learn. And I don't have any much else besides that. Any last words?
No, thank you for inviting me to the conversation. Be happy to join at any time in the future if you see the need. I mean, certainly patients with chronic liver disease, they're going to have nutrition problems, and they're going to benefit from not really sort of specialized nutraceutical-y things, but crafting their diet to be um, digestible and rebuilding their bodies.
Hmm. Yeah. All right. Um, Thank you all so much for viewing. Thank you again, Dr. Mark Manary. And we'll see you all in the next one. Take
All
care.
right.
Bye-bye.
Be strong.